I know I've counseled many women and cared for many women who've become very frustrated. Like, why didn't my doctor do anything more? Why don't they offer anything else? And I say because we are taught that 50% of the time it's chromosomal abnormalities, and it seems like, well, half the time I can't do anything about it, right? But
Mm-hmm.
the other
Right.
half of the time there are things that can be done.
Hi there, and welcome to Caring for Both, a curbside consult series by the American Association of Pro-Life Obstetricians and Gynecologists, or APLOG. I'm Miriam Diallo, APLOG's Communications Manager, and if you listened to last week's episode, you'll know that I'm not the host of this week's episode. This is part 2 of a 2-part conversation between Dr. Susan Bain, the host, and Dr. Marguerite Duane, the Executive Director of Fertility Awareness Education Organization, Facts About Fertility. Their conversation is about the modifiable risk factors for and prevention of miscarriage. And in part 1 of this episode, they discussed a primer on the different classifications of miscarriage and the importance of understanding the modifiable risk factors for miscarriage. And in the second part of this conversation, they're actually going to dive in and talk about what those risk factors are and how to address them. So with that, we'll go ahead and jump right into their conversation, and I hope that you enjoy.
As we do think about the causes now, tell us a little bit about that, because people are going to want to know why did my baby die?
Yeah, yeah. And when we look at the cause of miscarriage, the number one cause of miscarriage, and unfortunately, this is based on old data that has not really been updated. And we need more research in this area, and something, again, I'm hoping to do through my work at Duquesne University. But the leading cause of miscarriage is chromosomal or genetic abnormalities, right? Perhaps it's damage to the sperm or to the egg, or as the sperm and egg unite and fertilization occurs, and the human zygote begins to rapidly divide. There can be genetic changes that happen that affect the viability of the pregnancy or the viability of the embryo. And it's estimated that about 50% of miscarriages are due to chromosomal abnormalities. Again, abnormalities in the genes or the chromosomes as the embryo is developing. That's 50% of the time. And the reality is that there isn't anything that we can do to prevent that once the embryo has been created, once the human zygote has formed. But there are things that we can do to ensure, to optimize the health of the woman and the man ahead of time, to ensure that they are producing or developing a healthy egg and healthy sperm, to reduce that risk of genetic abnormalities that can lead to miscarriage. Unfortunately, as our society, is eating more processed foods, exposed to more toxins, we're probably moving in the opposite direction when it comes to minimizing factors that can, adversely affect the genetic makeup of the gametes, the sperm and the egg that create the embryo. But 50% of all miscarriages are due to genetic or chromosomal abnormality with the embryo. And unfortunately, that is not something which we can prevent. And I think that's why, I know I've counseled many women and cared for many women who've become very frustrated. Like, why didn't my doctor do anything more? Why don't they offer anything else? And I say because we are taught that 50% of the time it's chromosomal abnormalities. And it seems like, well, half the time I can't do anything about it, right?
Mm-hmm.
But
Right.
half of the time there are things that can be done. There are things like maternal anatomic anomalies, right? Such as a bicornuate uterus where there's a septum in the uterus. Sometimes there may be fibroids. Again, this is a disease that affects women that can distort the anatomy of the uterus and affect implantation. Endocrine disorders are a very common cause of miscarriage, whether it's thyroid disease, inadequate progesterone, inadequate estradiol, insulin resistance. There are a number of endocrine dysfunction and disorders that can affect and increase a woman's risk for pregnancy. For example, with thyroid disease, as a physician, the test we normally check in women to screen for thyroid disease is the TSH, or thyroid stimulating hormone test. And if you look at your lab normal values, the normal value for TSH, the standard normal value, is anywhere from 0.5 to 4.5 in the adult population.
Right. Big range.
That adults include both men and women. And
Mm-hmm.
men hormones and male hormone levels are not necessarily the same as women. And so to conflate them all into one is somewhat misleading. The American Society of Reproductive Medicine, or ASRM, has found and has guidelines that women with a TSH that's greater than 2.5, which is in the middle of that normal range, if
Right.
TSH is greater than 2.5, they have a statistically significant increased risk in both miscarriage and infertility. So when I see a woman and she's like, oh, I've had my thyroid checked and it's normal, my question is what is the number? And oftentimes it's like 3.5. I'm like, that's not normal. And again, most doctors may not know that, and they may not pick that up as an abnormality. As an example, of course, progestation, it's the key hormone in pregnancy that's important for supporting that pregnancy. I mean, it's produced by the corpus luteum. If you've had poor follicular development, poor corpus luteum function, the corpus luteum may not make enough progesterone to maintain the uterine lining, and that can lead to an early pregnancy loss. And in pregnancy, the corpus luteum is really responsible for producing progesterone and estradiol for the first 8 weeks or so of the pregnancy, at which point the placenta will take over the production of progesterone and estradiol hormones. Well, sometimes if that corpus luteum begins to disintegrate, doesn't function as effectively or as long, and the levels start to drop, we may see a rise in miscarriage rates. In fact, that's what we see. The highest rate of miscarriage occurs at about 8 weeks gestation. And this is about the time that the corpus luteum is beginning to fall off in its production of hormones, and the placenta should be kicking up. But if there's a gap, that can result in a drop in hormones that can lead to pregnancy loss. Progesterone is important. Estradiol is also important, and there was a research study published in January of 2024 by Dr. Phil Boyle, a family physician who developed neofertility. And what he found in looking at women for close to a decade, in pregnant women who had normal hormone levels, normal thyroid, normal progesterone, normal insulin, but had low estradiol levels, their miscarriage rate was 45%. That is 3 times the average of the 15 to 20% miscarriage.
Right. Yeah.
And what he found, for 3 years, he gave women with low estradiol levels, he gave them estradiol and look at the miscarriage rate. And he found that in those women, the miscarriage rate dropped 21%, which is tremendous. It dropped by less than half. But as you know, as an obstetrician and gynecologist, estradiol is not without its risks, including the increased risk of blood clots. And so Dr. Boyle then actually tried giving women DHEA, which is a hormone, dihydroepiandrosterone, that is a building block that the woman's body uses to make estradiol. Now, it also uses DHEA to make testosterone, to make cortisol, but your body needs DHEA to make estradiol. And in the population that Dr. Boyle gave DHEA to, the miscarriage rate dropped to 17%, which is tremendous. Again, I spoke to a woman last summer who had 2 miscarriages. She was seeing a Creighton-trained doctor who knew about the importance of progesterone, but her estradiol levels were low. And this doctor just simply wasn't aware because the research is so new. And it's important that we share this research. And it's also important, that we empower patients to bring this information to their doctors, but to not treat themselves, right? I mean, because there are risks associated with this, so it is important. But hormonal issues are huge. And then, of course, things that we commonly think of, autoimmune disorders, infections, sexually transmitted infections, for example. And this is why it's so important that people are really thoughtful and mindful about their sexual behavior, because it can have profound implications later on in life. And then, of course, blood clotting disorders. So there's a wide variety of factors that can lead to miscarriage. Unfortunately, as physicians, we're simply trained. It happens. It's common. We won't look into doing anything about it until a woman has had 2 or 3 miscarriages.
Yeah.
Which is heartbreaking that we would ask them to go through this loss 2 or 3 times before we even say, let's try and figure out what's wrong.
Right. Yeah, that makes no sense. It never did when I was taught that. So when we think about helping women like who've had a miscarriage and are going what went wrong, and that big list of potential root causes, Talk to us how, if you go to someone who is trained with the restorative reproductive medicine approach, how that's going to look. And if one of our listeners is, whether it's a patient or a professional who wants to learn more about that approach.
Yeah, great question. And I will say, and again, I said this at the beginning, I'm trained in multiple, restorative approaches, the Creighton model, FEM, neo-fertility. All three of these actually inform the care that I provide patients. And I think that's one of the challenges, because if you see a doctor who's trained in Creighton, they are going to recognize the importance of progesterone and probably will also check thyroid, but they may not know about the latest research on the important role of estradiol from a hormonal perspective. It's also important, again, that we're doing this anatomical survey. Last year I had a new patient. She had had one miscarriage at 8 weeks. She came to me and actually was pregnant, at her first visit, like very, very early, but then lost that pregnancy at about 5 weeks before we'd even had a chance to do any workup. And I did an ultrasound in her as part of my basic workup. I'll do a hormonal profile looking at all of the hormones, and we time the testing of the hormones based on the woman's cycle. And this is where learning to chart with a natural or fertility awareness-based method, whether it's Creighton or FEM or neo-fertility or one of the other methods, the chart really is critically important to help us look for potential factors that may be leading to miscarriage and to time the testing of the hormones and the ultrasound. So in this patient, I did an ultrasound, and it was very clear that she had a bicornuate uterus. She had a septum, and if the embryo tries to implant in the septum, it's not going to be able to sustain the pregnancy. So when I see a patient, I am going to first ask them to begin charting if they're not already doing so. And I can look at even 1 or 2 cycles, and I can see, does she have a short luteal phase, which is the second half of the cycle? Does she have a short follicular phase? Does she have inadequate mucus production? Does she have spotting at different points of the cycle, which will indicate different things? Mid-cycle spotting, may indicate polyps. Spotting throughout could indicate chronic endometritis. Spotting right before the period could indicate an inadequate progesterone levels. So these are all factors that I am going to assess and incorporate into my diagnostic workup. And then I'm going to do, like I said, a basic hormone profile, looking not just at estradiol and progesterone, but looking at the full hormone profile: follicle-stimulating hormone, thyroid-stimulating hormone, testosterone, insulin resistance is a very common cause of ovarian dysfunction. I'm going to do a survey of what are their environmental exposures, and look again, and this is why I love the fact that I'm a family physician, because I'm trained to look at both the woman and the man, right? And we often think of like miscarriage, infertility as a female health issue. It's not. I mean, it takes 2 people to make a baby, right? And the male factor is important with infertility and the miscarriage. So it's important that we're assessing both of these. So I'm going to have a woman, chart for a month or 2, time laboratory testing, and then potentially time ultrasound testing to evaluate for the full range of factors. And again, I'm a family physician, and a main part of our focus is in prevention, right? I don't want to wait until you've had 3 miscarriages or 2 or even 1. When you're trying to get pregnant, I want to look at your chart right from the beginning and look for, here are some things that could potentially lead to miscarriage. Let's work to address them now. Let's prevent that first miscarriage. But as you know, there's still so few medical professionals that are trained in fertility awareness-based methods and restorative reproductive medicine, and that's primarily the work that we're doing at FACS to really grow that. And to give women access, we've created a directory of FABM trained physicians, clinicians, and educators to help people find doctors that are trained. They can visit the directory through our website. I know Natural Womanhood and the Fertility Science Institutes has a directory, and there are certain organizations like Creighton and FEM have directories of their doctors, and then My Catholic Doctor is another source for people to get access to restorative reproductive medical care through telemedicine. So really educating yourself and then sharing that information with your doctor. And I've said I'm always happy to talk with any doctor about this. So if you're a patient, you're going to your doctor and they're like, I don't know where to begin, like I don't even know how to talk about it, tell them you can talk with Dr. Duane at FACS. I mean, I'm happy to have a conversation with any medical professional that wants to learn more so we can support them in better caring for their patients.
Yeah, so thanks for empowering the listeners who are patients on all those sources. So how about those of us who are healthcare professionals who want to become trained more? Where would you tell those listeners to go to learn more and possibly be able to sign up for training?
Yeah, again, that's a great question. But before I do, I want to touch on one other factor for your patients in terms of the risks. Probably the most important risk factor that I did not mention, and it's questionable whether or not this is a modifiable risk factor. I would dare say it is, but the most important risk factor for miscarriage is age. The reality is that the risk of miscarriage is high in very young women before the age of 20 and goes up dramatically in women after the age of 35. It's really starting to increase at 32, and certainly after 40 the risk goes up dramatically. And again, I raise the question, is this a modifiable risk factor? No, if you're 45, you can't turn back the clock and be 35. But if you have listeners that are listening in their early 20s or mid-20s or late 20s and thinking like, I'm just going to wait until I'm fully established and everything I'm doing and I've got a house and everything is all set, and then we'll start trying. I really want to encourage people, there is no best time to have a baby from a being ready perspective, but there is a best time physiologically to minimize your risk of infertility and miscarriage, and that really is for women and even men in their 20s and early 30s. And so again, I just want to encourage your listeners to think through that. And I think we as a medical community and as a society, we need to make it easier for people that do want to have children in their 20s to be able to do that and simultaneously continue on the career path that they're choosing,
Right. It's not either or in terms of that. And I appreciate you bringing that up, because I don't think all women realize that their losses really go up in their early 30s, and there is kind of I think it's a duty of us to share that information. Now they can choose to wait,
Right.
but if they choose to, that is a risk factor for miscarriage. So as we close up, I'm a practicing OBGYN. I want to learn more. Where are you going to tell me to go, Marguerite?
So it really depends on you and what training you have had. So obviously, I think that the education that we offer through FACS is fundamental and it's foundational in that we educate the medical community about all of the evidence-based methods and their broad applications. We have an online CME course that consists of 13 parts, and each part is worth up to 16 CME credits that's approved through the American Academy of Family Physicians. And you will learn about each of the evidence-based methods and their approaches. I like to describe the education that we offer at FACS. It's like your first 2 years of medical school, right? It's fundamental. It's foundational. You really need this before you can go into your third and fourth year.
Right.
Beginning to learn those clinical applications. But once you have that foundational knowledge, then we do encourage, and through FACS, through our FACS membership program, we work with organizations like Fertility and FEM to get medical professionals trained in neofertility and FEM. And then, of course, there's Creighton as well. All three of these offer that next level of training. But again, as somebody who's trained in all three, a single one of them is not enough. Maybe you only have time to do one, or you want to do them sequentially, and that's okay. But I would encourage you, especially for people that are still early on in their career, to think through, how can I get trained in all of these? So again, we encourage people to visit the factsaboutfertility.org website under Learn More to find our CME course. That really is the ideal place to start. And for people that are members of FACS, there's a 20% discount on our CME courses, as well as on our training programs, our cohort training programs, like we referred to with our partner organizations, Neofertility, FEM, and then of course Creighton training are all excellent training programs. And down the line, we hope to be offering more in terms of fellowship opportunities, electives for residents, in addition to the electives that we offer for students, so that we can train the medical professional community, educate the medical professionals, so they in turn can educate and empower women and men and really engage them in the care of their fertility and reproductive health.
Yeah, thank you so much for teaching our audience about miscarriage, as well as getting to the root cause of them, and as well as helping professionals know that, if this is an area that they don't feel like they've gotten adequate training, there are ways to really improve that. So,
100%. And
yeah.
I want to end with this. Like, I want to highlight it because I think it's a really inspirational story. So, at our Pittsburgh conference at Duquesne University on March 21st and 22nd, our closing keynote speaker is Dr. Anita Showalter, who is a practicing OBGYN, and she is the division chief of specialty medicine at Duquesne University. So, a very high up position. But she's going to share her own personal story of getting married at a young age and having a family before even going to college and medical school and building a very successful career. And so we've titled her talk Having It All but Not All at Once, and really people to rethink the order in which we do things so that we can work with our bodies when we are at the healthiest and the optimal time to really grow our family, because my goal is to reduce as many miscarriages as possible. I like to consider myself a first trimester care expert. We talk about fourth trimester doctors that really focus on that postpartum period. I see my role as a first trimester care expert to really help people have the healthiest first trimester and prevent pregnancy loss from the very, very beginning.
Oh, I love that. So thank you, Marguerite Duane, the first trimester doctor who has lots of expertise and energy around this topic. So, and thank you to all our listeners for joining us today. If you like this episode, be sure to give us a like, subscribe on our YouTube channel. If you're listening on a podcast app, just go ahead and give us a 5-star review. We will happily see you on our next episode. And remember, if you want the full scope of this, Dr. Duane's going to be talking at MBEC, and we'll have those ongoing CMEs so you can learn more. Have a great day, everyone.